области
His work
наркозависимости
let us
и
understand
снижения
that
вреда в
harm
целом.
reduction is
И
not
он помог
an
нам
abstract
понять, что
concept. It
снижение
is
вреда–
a
это не
very concrete
абстрактное
public health
понятие, это
approach
конкретный подход
based on
в
evidence
области
and the
здравоохранения,
values
основанный
of
на
human
доказательствах, на
life.
ценностях,
He's also
таких
one of the
ценностей,
founders
как и
of the
жизнь
Knowledge Action
человека.
Change, the
Он
organization
стал
that I
одним
also
из
represent here today.
соорганизаторов и
Terry, thank you
сооснователей
for being
Knowledge
here with
Action
us,
Change, и
and
я
the floor is
представляю Knowledge
yours.
Action Change. Герри, пожалуйста, тебе слово. Огромное спасибо, Татьяна. Меня нет в повестке дня, поэтому это сюрприз. Я хотел только поприветствовать вас всех, поскольку мы все занимаемся вопросами снижения вреда. Итак, вкратце, мой опыт в области снижения вреда и как это связано с темой сегодняшней конференции. Большое спасибо, что вы прибыли на эту встречу. Огромное спасибо Татьяне за то, что она как раз рассматривает важное снижение вреда с представительством целого ряда регионов. Для того, чтобы было безопаснее был секс, было безопасное, более безопасное употребление табака и никотина. Это связано с ценностями, которые для нас важны в области практики по снижению вреда. Это важно для того, чтобы помогать курящим справляться с этой сложной проблемой. Это важно для людей с ВИЧ, с туберкулезом, тех, кто употребляет наркотики. Это важно для представителей системы здравоохранения. Это важно для населения, в частности, населения малоимущего. Это важно для всех, кто сталкивается с риском зависимостей. Чем я интересуюсь? У меня длительная карьера научного сотрудника. Я занимался вопросами наркозависимости. Татьяна обратила внимание на то, что у меня уже десятилетие опыта в области лечения наркозависимости и рассмотрения это с точки зрения снижения вреда. В 80-х, в 90-х это понятие стало более распространенным. Меня интересует эта тема, и я этим занимался в своей работе, также с точки зрения общественных моментов. Снижение вреда– это очень доступное понятие, и мы предпринимаем меры, чтобы снижать риск. Одним из моих любимых примеров является то, что водитель, который ведет, например, мотоцикл, и мы говорим, что это рискованно, и мы же не не лечим людей от зависимости в области виде вождения автомобиля, либо мотоцикла, поскольку это связано с рисками, мы просто снижаем риск, рискованное поведение, чтобы не приводило это к ДТП, чтобы люди после употребления алкоголя не садились за руль. То есть это один из примеров того, как можно ограничивать, снижать риски. Мы рассматриваем среду, в которой распространяется риск зависимости. Мы рассматриваем поведенческие установки, ресурсы, которые имеются для снижения риска зависимости. И мы хотели бы, чтобы все были более безопасными. Снижение вреда связано с тем, что мы формируем соответствующее безопасное поведение, и специалисты
as the case may be, stand in the way. So harm reduction is basic public health. It's also a human right. It's the right for people to have the information and the circumstances and the resources to lead healthier lives. So harm reduction is easy, but of course when it comes to drugs and sex and communities that would benefit from harm reduction, there are huge obstacles, which include stigma, hatred, intolerance, deprivation, impoverishment, abuse of human rights, and prohibitions on safer products. So although harm reduction is easy, it's also not easy. So Where did it start? Well, I think we often think of it starting in the 1980s with the arrival of HIV/AIDS, but there's a much longer history of harm reduction, although it wasn't called that. For example, in the UK, doctors were able to prescribe heroin to people addicted to heroin from the 1920s. In fact, there's 100 years of that policy. Still a few people are prescribed heroin, but that was done explicitly in order that people would lead relatively normal lives whilst using the drug to which they were addicted. Now, that continued in the UK through to the late 1960s, early 70s, and my first research was actually on people who were being prescribed heroin in London, and my research contributed to some understanding of the sort of people that would help. A bit of the puzzles, it helped some people it didn't help. It was also the time, this is early 1970s, when I became involved with one of the first community drug projects in London, which was aimed at giving sort of day care, day service, just a safe place for drug users in a community in South London. Many of them were being prescribed heroin, and they used to inject in the local park, but the centre was set up as a place that they could go to, which was a benefit to the drug users, but also benefit in a way to the other users of the park. And the person who developed that project, Susan Martin, described it as a place where people could spend time without fear of harassment, she said, and also to have a chance to join in a community which doesn't reject them and which it hopes they will not find it necessary to reject. So early on, I sort of realized the importance of making contact, reaching out to people, providing safer spaces, offering help without excessive demands and expectations. So harm reduction is more than health and safety, it's also compassionate. It's what someone once described as the opposite of stigma and hatred. Thinking back to that period in the early 1970s, I remember now that we had a space in the community project where people could inject. It was probably the first fixing room, the first safer injecting room to operate in the UK. It didn't last that long for a number of reasons, but it was an aspect of saying, people are going to inject, where can they inject? Can you make a safer environment where they can inject? Skip forward to the 1980s and the arrival of HIV and AIDS. The HIV antibody test was introduced in 1985, and within a year it was soon realized that many people who inject drugs were HIV positive. Some of the early testing in the UK found, in particular in Scotland, that up to 50% of people who injected had become HIV positive within the space of a couple of years. Very rapid spread of HIV infection. So alarm bells, and similar reports were found around much of Europe, and the UK was one of the first countries to make needles and syringes available to people who inject. And I was brought in by the UK government to evaluate that project, and it was very successful in contacting people, helping people change their behaviour, and the UK as a consequence has had an extremely low level of HIV infection amongst people who inject drugs. A side note, the first needle exchanges were not developed by local projects or by governments, but were developed by in the early 1980s in Rotterdam by the Rotterdam Junkie Bond. The Junkie Bond was a union of drug users who persuaded the city to make needles and syringes available to them in order to curb the spread of hepatitis B. So again, it's often affected communities that start harm reduction and do harm reduction. It's not experts who do harm reduction. So in 2004, I had a bit of a crisis moment and gave up academic research. I thought this was a little bit boring and I'd made a a poor career choice. There were other things to do. So I went then to run the International Harm Reduction Association, which was later called Harm Reduction International, which was there to persuade UN agencies of the importance of drugs harm reduction, many of whom were against drugs harm reduction. The United Nations Office on Drugs and Crime always had a difficult relationship with harm reduction under pressure, partly from the US government, who was a major funder. WHO rejected drugs harm reduction. Conference that we held in Switzerland, WHO staff were banned from coming because it was about making life, about reducing harm to drug users. But anyhow, that all changed over time. And whilst at International Harm Reduction Association, we were very lucky to have a grant from the UK Department for International Development, and we used that money to seed the development of many organizations, including Input. We were the first funders of Input, and also Manara, we were the first funders of Manara, and Youth Rise, and a number of other things that have gone on to have quite successful lives since then. So I came to tobacco harm reduction from drugs harm reduction, and kind of why tobacco harm reduction? Well, firstly, the sheer scale. I mean, nicotine is the world's most popular drug, well, alongside caffeine and alcohol. It's one of the top 3 drugs. Over 18% of the adult population smokes tobacco. There's nearly 1 billion smokers globally, and insufficient progress has been made by national governments and international organizations to help bring an end to smoking. Smoking annually kills more people than HIV, TB, malaria, and illicit drug use. That's a bit of a sobering thought, because a lot of our work has been in those areas, but smoking kills more people than those areas combined. The problem is that when you burn tobacco, it releases thousands of chemicals and causes high levels of morbidity and premature death. The way in which tobacco control has developed has been to focus on reducing demand and reducing supply, aiming for a tobacco-free world. And you might see how that resonates with people who want to create a drug-free world, so a vision that there'll be no tobacco, no smoking, that it can be made to disappear by making it difficult to produce and sell, taxing it, and making life difficult for smokers. And when I came to tobacco harm reduction from drugs harm reduction, I was stunned that public health people would talk about stigmatizing smokers as a way of helping them. You know, all the work that's been done in drugs and AIDS and everything else is all about destigmatization. But here you have public health people saying, you know, encouraging hatred of smokers, encouraging dislike of smokers. So too many sticks and not enough carrots. So the cigarette, it's a dirty delivery system, and in a way there were not many opportunities, not many harm reduction opportunities until the invention of the e-cigarette in early 2004, which kind of changed the game. People could now enjoy nicotine with a vastly reduced risk of harming themselves. So recreational, guilt-free nicotine use was now possible. So there are now many nicotine delivery systems, vapes, nicotine pouches, Swedish snus, heated tobacco products, all substantially safer than smoking. So people can now use nicotine in a way that won't kill them. So part of what's been driving this has been consumers. The early days of tobacco harm reduction were just, were community initiatives, community smokers' choices. Little organization there were vape fests, there were online fora offering advice, but that's grown to a proliferation of the dozens of vaping advocacy groups worldwide. So the outcome of this is that where tobacco harm reduction has been accepted and tolerated, there have been major reductions of smoking, and there are lots of good examples in the UK, for example, in New Zealand, in Sweden, Norway, Japan, Iceland, where smoking has just dropped. in fact, in some of those countries, vaping or the use of other drugs, or other types of tobacco, such as snus, has overtaken. There are more vapors in the UK now than there are smokers. But there are problems. WHO supports drugs harm reduction, but runs misinformation campaigns about safer nicotine products. You can't trust WHO on this topic, and that's difficult for many of us who've had long histories of working with WHO. US foundations campaign against tobacco harm reduction. The same foundations support drugs harm reduction. The lead International Harm Reduction Association is scared to engage with tobacco harm reduction. So this disconnect between drugs harm reduction and tobacco harm reduction plays out, I think, in many sectors. Probably plays out at a service level. In drug treatment services for sure, in services of HIV, I guess, in TB services, and so on. Now, amongst drug-using populations, there are hugely high smoking rates. Our recent bit of research with Attica in Kyrgyzstan found that nicotine use was almost universal. 99% of drug users in touch with harm reduction services in Kyrgyzstan used nicotine, and 80% were smoking. And that was the same for men and for women. And for women, that's an extraordinarily high level of smoking, because the background level of smoking in Kyrgyzstan is about 3%. So amongst women, female drug users, the smoking rates are 25 times the national average. So I think as we start to explore issues of women and smoking, we're going to find that in mainly smoking is a male issue. You know, explore why that might be the case. But in special populations, very high levels of smoking. And smoking now appears in some studies to be as responsible for as many deaths amongst drug users as drug use. A recent study in the UK of 100,000 heroin users, following them over time, found that the mortality rate from amongst drug users, heroin users from smoking was around 28%, and death rate from smoking amongst that population was 24%. So again, that's quite stunning. We focus on drug-related deaths, but smoking is also a cause of death. So whilst this is all going on, I think services have often either disregarded smoking or found it one of those things that's a bit difficult to tackle. So I'd be very interested to hear today in these two sessions about ways of tackling smoking amongst women and also amongst people with TB. So addressing smoking and risky tobacco use should really be a priority for all services supporting people facing difficult health and life problems, but it isn't. And really, tobacco harm reduction is one of the simplest things you can do at a basic level. It's just telling people there are alternatives, but I know life is more complicated than that. So with that, rather more than a few words I was allowed to say, that's how I came to tobacco harm reduction, and I look forward to hearing today you discussing issues of smoking and tobacco harm reduction in a couple of very important populations. So Tatiana and everybody, thank you very much.
Okay, thanks a lot. Thank you very much, Jerry, for this wider perspective and backwise perspective of harm reduction. And well, you know, something tells me that as it happened with drug harm reduction, it will happen the same way with tobacco harm reduction, that it will be the communities who will lead the change, the real life change for real people in concrete contexts on a planet. And with this, we are turning to our gorgeous and very knowledgeable, very experienced panel of presenters. Today with us, we have Evgenia Karatkova from Uzbekistan, We have Lyubov Vorontsova from Kazakhstan and Alla Besonova from Kyrgyzstan. All are tremendously experienced and prominent advocates and activists from their countries, known beyond the countries, and who have brought a lot of change for people living with HIV, people who use drugs and have other vulnerabilities. I'm happy to start this session with Evgenia's presentation on the triple stigma women experience in Uzbekistan because of different and complex situation they have in the country due to various reasons. Evgenia, the floor is yours. We are happy to have you with us today. This presentation will be delivered in Russian, so please get prepared for the translation.
Наверное, сразу надо проверить, работает ли трансляция сразу перевода. Потому что, да, у меня технически я не смогла подключиться, поэтому, коллеги, пожалуйста, проверьте, чтобы у нас
okay with the
было общее понимание. Ну, еще раз доброе утро. В моей стране уже достаточно день.
Actually, later in my country, it's lunchtime, and here it's morning, so good morning. Let me welcome you all. Thank you for your attendance, and thank you for organizing this forum, because HIV, women living with HIV have this opportunity to share our experience, our opinions, the opinions of our community. Unfortunately, it's not always the case that research takes into account personal experience. So some researchers focus on figures, on numbers. Figures is one thing, but it reflects a human being and a personal experience of a given person, and we shall do everything to support people. I'd like to share some of the results of our research on the experience of women living with HIV in the context of tobacco and nicotine use. During pregnancy and after childbirth, and they used tobacco during pregnancy and after childbirth. Speaking of tobacco and healthcare, we usually discuss risks and statistical data. And we do not often hear the opinions of women themselves. Why do they do that? What are their fears? Why do they not refer to healthcare services and healthcare providers for help, for support? So today I'd like to share our experience, and I'm not only going to tackle the issue of tobacco use and nicotine use, taking into account the Central Asian context. We would like to tackle the issues related to what pregnant women or women after childbirth, what issues they're facing. I'd also like to mention a few words about our activities in Uzbekistan. We have the public organization for people living with HIV, and one of the areas of activities focuses on women living with HIV. And we are very experienced. We work promote access to services and going beyond the gender bias, because there is the vertical transmission, of course, and in our country one of the most important factors is the program on reduction of HIV transmission from mother to child, and we support access to services. We work in 9 regions of our country, and we offer community support to these women. Initially, it was not very easy for us to start working and collect interviews, for example, because of the barriers, because of stigma that interfered with our efforts. And I'm going to share our experience with us. One second. As I've mentioned, initially we faced the issue of the topic of tobacco as absent from HIV services, support during motherhood and after pregnancy, and those institutions dealing with prevention did not actually tackle this problem. So there are certain services based on protocols, there are screening programs as well available. But speaking of tobacco harm reduction, we didn't see any initiatives of this kind among the public institutions. So our research showed that women face a number of challenges on different levels we are going to discuss. So a woman herself, a woman who is a mother, and a woman suffering from diseases and HIV in this case, and who is using tobacco and nicotine. So this group is not targeted or was not targeted by official system. The context of such women was disregarded, and we hope that our research will give women an opportunity to speak up. Their voice is going to be heard because it's very important, and our voice will be heard by healthcare professionals and social services and welfare services providers. We've mentioned that healthcare system plays a key role in offering services. Unfortunately, we've seen that the system doesn't see the issue of tobacco use. In the majority of cases among our respondents, it was difficult to cope with stress, for example, anxiety, fears, emotional issues. And we have seen that there was some blame, judgment, and pressure on them, which does not limit tobacco use. It just makes this issue silenced and it remains hidden. So the system doesn't see these women and their needs and doesn't understand the reasons for such behavior. So, of course, when you receive a recommendation from healthcare professionals, the recommendation is one thing, and living in a family, hiding your tobacco use, for example, from the family members and from the surrounding, the milieu, and when you actually raise your children, some women are single mothers, which makes this situation even more difficult, and they're facing stigma, which is multifaceted. And research has shown that when we interviewed our interviewees, this so-called triple stigma was observed, which means that they face several types of stigma, that they are HIV positive. This is one type of stigma. In our countries, we are facing stigma that a woman is HIV positive and pregnant, and the HIV status, and she's pregnant, and in addition, she uses tobacco. So this is the triple stigma: tobacco stigma, HIV-related stigma, and gender-based stigma. So there is a certain expectation that a woman should be healthy, first of all. This is the social expectation. And if she is unhealthy and has an unhealthy lifestyle, it is stigmatized, and there is this blame on her that she is the one responsible for these conditions. And of course, women do not speak openly about themselves. They do not disclose this information to their doctors, for example. We have also seen that our interviews mentioned not only the context of nicotine and tobacco. They disclosed information. They don't want to be seen as bad mothers from the point of view of neighbors, of healthcare professionals, and the milieu. So there was a lot of cross-sectional aspects. Many interviews had this experience of all types of manifestations of stigma in their lives. So when they accessed healthcare services, for example. We are aware that pregnant women and young mothers have their difficulties, and society has certain expectations as regards them. They're expected to be ideal mothers, ideal women, which worsens the situation of these women, and isolation is even deeper. Another important component is gender and control over women. We all know, and recently it has been noticed, it is on the agenda in many countries to deal with these gender-related issues, but awareness doesn't change overnight. It takes some time to change attitudes. Our research has shown that gender aspect plays a very important role. So when a man is smoking, this is one thing, but when a woman is using tobacco and is smoking, it is something different. For example, when she is pregnant or after the childbirth, she is morally assessed in a negative way. So she's thinking that there are stereotypes, and she has this burden during her lifetime. And if she's an HIV positive woman, she feels this social judgment. It's not only about health, also the issue of control over women was mentioned by our interviewees, that there are certain expectations, the way she should look like, what she should be talking about, does she have a right to make a mistake, or is she going to be blamed for any mistake? And an HIV positive woman does everything possible to give birth to a child without an HIV infection. So she takes care of her newborn. The focus is on a child, of course. This is the priority for every woman in general. What else? In the context of this gender aspect, women come across different social judgments, especially when she's pregnant or has just given birth to a child. And there is social and economic dependence or control. There are certain expectations women are expected to obey and UN stays silent, for example. There are some other issues as regards control on behalf of family members, which aggravates the situation. So when control affects access to services and affects decision making, it is very difficult for a woman to decide about her health and her access to services. Her family controls her. For example, we sometimes have extended families, and women may be sharing a place with her parents, apart from her spouse, for example. So this is up to our tradition, to the national context, extended families, and you have huge respect to older generation, and spouses sometimes live together with parents and grandparents.
Therefore, a woman does not always have time for herself and to be for herself. As in our social setting, a woman is to keep the family and the house. She's there to take care of the health and well-being of the parents and of the children, and therefore there is not much time left for the woman herself. So the priorities are different. Therefore, once a woman feels this being judged all the time, and this judgmental setting is such that a woman finds it difficult to seek help. Therefore, as for tobacco harm reduction approach, it must be gender sensitive, and it must be based on human rights and respect to women. Now, what do we know from our survey? We have seen the main paradox. Perhaps that was the most potent conclusion from this research, that women are already motivated for change. They want to change. The research shows that in most cases, women were trying to reduce their use of tobacco. In most cases, women were trying to drop using, to quit using cigarettes and nicotine. And as I've said before, in their majority, and all of the women are worried about the health condition of their children. So the problem does not lie in the motivation of these women. They are motivated. The problem is different. It's about providing them with safe support. Once the system is judgmental, where there is a lot of moralizing, where there is so much judgment, these women do not speak openly. They're not being honest. In this research, we have seen what women say between the lines. As we were interviewing them, we received some messages between the lines, and in most cases we see that women wanted not to be blamed or intimidated. They want to be heard. They want to have a possibility to speak out. For me, this is the most humane type of research that we have carried out, where we have seen support begins not with treatment, but everything begins with a safe conversation. It turned out that so many women were not ready to come and talk to us. They were not ready to have an interview with us because they were scared. They had fears. And in most cases, we have been able to talk to women, but we have always heard about fatigue and anxiety. They're left all alone. They're not ready to talk about themselves and to talk about their needs. They're not ready to talk about their problems with other people, because they understand that they are going to be judged. So this research is a very important reminder. We need to remember that a person changes her behavior once that person is supported and not pressed upon.
Несмотря на нашу работу, и мы очень хорошо, то есть держим контакты, да, системы здравоохранения.
We are in good contact with the public health system. We are running many projects together with the public health authorities, especially in the area of maternity and childhood. Nonetheless, we have not seen that the topic of pregnancy, labor, perinatal period, and tobacco use are being discussed together. And if it is being discussed, then it's usually all about moralizing. But women were very clearly speaking about the big difference between a judgmental-based system, and the support-based system. So they were saying how it was actually, and they were saying how they would like it to see. So the public health system may potentially increase trust, and so that people will be attracted to the system, but quite on the contrary, it may happen that the system may scare people away. One woman, once I spoke to a woman, and I asked her, describe your relations with the public health system and how would you like it to be? So that woman, she was very clear in what she said. She said it in very plain words. So when you go to visit someone, and you're welcomed by the host, or you're not welcomed by the host, right? So once you go to that house, once you've seen your friends, and you leave the house, and you immediately know whether you were or were not welcome, would you like to go back and to see those hosts, or maybe not? And that was a very simple description of how it feels. We want to go there, and we want to be welcome. I simply need to have this desire to go back and return to that healthcare institution. It's just a simple example that shows the significance that people must be supported, people must be welcome, so that people want to go back. How about respect? Respect, love, kindness. Give them something to eat. it's, give them a treat. It's like you go and visit your friends. And many women were describing some positive examples when specialists were indeed helping them. But there was so much negative experience as well. We understand it perfectly well that there is a reason behind all that. The human factor is very important. Yes, there may be some minor system bugs, and system bugs it could be easily addressed. We do not need to run some global program to fix a local bug. We have also seen that effective harm reduction is not doable without trust. Many times, these women also act as consultants, but also we need to take into consideration mental health of women. So use of tobacco, HIV, and maternity should also be integrated with the issues of mental health, so it all work hand in glove. It's not that we should be treating these areas separately, one from another. We should be comprehensive about it. And that's... And that is clearly seen that harm reduction, it's not only about medical strategy, it's also about dignity. It's about giving access. It's about accessibility. And if a woman is open and honest about her nicotine use, then we may have a way forward. But if a woman cannot be honest, then we are coming up with some systemic problems. So we need to work on safety and trust. We know that harm reduction, it's not just saying okay to smoking. No, it's not that. It's about seeing the reality. It's just acknowledging the reality and acknowledging the needs of our women. So what do we suggest? First, we need to acknowledge that there is stigma and there is gender inequality. Those are main factors that have an impact on the health condition and access to services. Moreover, harm reduction should be integrated with maternity health programs and HIV programs. So it's all about prevention, because those are the places that women go to. So we need to work with the community of consultants. And the most important thing probably now is that we need to treat the healthcare professionals to be non-discriminatory in their approaches and communication. And we need to stop looking at those women through the prism of correct or incorrect behavior conduct. And perhaps my last slide would be this one. This is our work, the work that we do. I simply wanted to share with you some pictures that show the way we work together with women and their children. There is a consultant, a medical doctor. In this specific case, we cooperate with gynecologists and obstetricians. And this is so important that a woman indeed is supported both by healthcare professionals, but also supported by the community. We need to understand that any harm reduction must be gender sensitive. We should train our personnel, both the community workers, but also the healthcare professionals, to be gender sensitive. Moreover, we need to provide for all basic services. Provide all basic services for these women on the community level. So I have shared with you in brief the results of our survey. I will be happy to give answers to your questions, and you would be more than welcome to come and visit our sunny Uzbekistan, which is marvelous, which is beautiful. Thank you very much for your kind attention. I have a question. I am from Kazakhstan. I respect Uzbekistan a lot. I was to Bukhara last year. Yes, you have traditions at play. I would like... So, what do women use more? Do they smoke more, or do they use other tobacco, nicotine products? Well, let me describe that. In our case, we see that women use nasvai, usually nasvai, so that they're not seen, because there is no smell. So, if there is a room where there is, it is not possibility to smoke, they use nasvai. But most of them actually use tobacco. But yes, nasvai is very popular. So, if as far as harm reduction is concerned, we need to understand whether they smoke or they use nasvai, and then to switch from nasvai to nicotine-containing pouches. So, I think nasvai might be quite interesting here. And then the transfer to nicotine pouches. Yes, you're correct. But unfortunately, today's legislation in Uzbekistan is such, there is a ban. Yes, there is a ban. Yeah, that happened recently. I'm speaking about Uzbekistan. In Uzbekistan, and in Kazakhstan, they also banned. No, I'm not talking about nasvai. I'm talking about pouches. Pouches have been banned.
Thanks a lot, Evgenia, for your presentation.
Благодарю вас. Большое спасибо, Евгения. Благодарю вас за вашу презентацию. Вижу, что у нас еще есть несколько вопросов в зале. И будем же, конечно, отвечать на ваши вопросы после всех презентаций.
Огромное спасибо за презентацию. Мы увидели, что это основано на конкретном опыте. Мы увидели, что курение связано с целым рядом факторов в Узбекистане. А теперь Алла Бессонова,
The right questions asked by the communities in safer environments. Alla Bessonova is a veteran activist from Kyrgyzstan with a lot of achievements, and she, including the International Jude Byrne Emerging Female Leader Award in 2024, and we are very happy and honored to have you with us, Alla. The floor is yours.
Before I start, I want to pay attention how important is to make community-led assessments and researches, and what we can find when we use community-led approaches. I want to start with a single number, 26. Что происходит? Yes. I want to start with a single number, 26. This is how many times higher the smoking prevalence is among women who use drugs compared with women in a general population in Kyrgyzstan. Not twice, not 5 times, 26 times. For men, the difference is only 2.5 times. This means the gender gap in smoking, men smoke more than women, virtually disappears in our group. Women with drug addiction smoke almost as much as men. Our work in harm reduction program, and we know our clients' HIV status. We know what drugs do they take. We know their history, but we never ask them about smoking. And I also want to tell you now one quote. Women who was participant in our research. She told, "I know I'm destroying myself every day, but I simply can't calm down. without a cigarette. The Data Attica 2025 researchers is the first research of nicotine use among people who use drugs in Kyrgyzstan. Few key figures: 26.8% of women using drugs in NGO-based harm reduction programs smoke, compared with roughly 3% of women in general KG population. 26 times higher, that is a gap for women. For men is only 2.5 times. 11.3% of women use vapes, compared with 2.7% of men. Women are already looking for less harmful alternative for their own. 5.4% of women use heated tobacco products, again higher than men at 1.9%. What does this tell us? Women in harm reduction programs are far more actively seeking less harmful alternative than men. They are not passive. They are looking for solution, but the system is not help them find one. Now why? This is not simply a habit. Look at the data. 81% smoked because they are addicted to nicotine. 80% to manage stress, expected. But here is the expanded part. 59%, more than half, smoke because a cigarette enhance the effects of drugs or reduce side effects. I think this is not psychology. I think this is pharmacology. Nicotine and drug interact at the neurochemical level. That means you cannot address smoking without addressing drug addiction. One more figure. 29% smoke to feel social connection. Smoking is a ritual of belonging. Programs, they simply say just quiet, ignore, or completely. Они переключают. Что случилось? Нет. Пятый слайд. Еще. Ага, спасибо. Okay. One more. I'd like to mention these women know perfectly well they smoking is harmful. They know, but 79% feel they should not be judged for it. And they are right. But here is a critical point. 61% believe the effective help them quitting simply does not exist. And 47% thinks you can only quit without willpower. Professional support is not needed. This is not ignorance. This is a rotation response to a system what has adapted them. If the system never offered them real support, how would they know it exists? Particularly striking, 50% believe that quitting smoking during rehabilitation is dangerous for their sobriety. It can be assumed that this is perspective among people who use drugs in a consequence of lack and accurate information about the interaction between drug use and smoking. how they try to quit. This is the most revealing slide for understanding the system failure. 85% try to quit on their own, without any help. This is not a choice. This is the absence of choice. Government services are effectively closed to this group because of fear and stigma. 33% switched to vaping, and it worked. They found the solution themselves, but from 1 July 2025, vaping is banned. Only 5% use a psychologist or cognitive behavior therapy. The tobacco quiet line was used by 1%. Almost nobody. Not because they don't want, because they don't know about it and don't trust it. Context. Kyrgyzstan has done a great deal for harm reduction. Since 1999, needle exchange, methadone therapy, HIV testing, genuine achievement. Formally, a support system for smokers exists too. The Republican Health Center, which a 24/7 quiet line, tobacco's recommendation, but for our women, this is not work. They will not go to governmental center. They fear disclosure, registration, police, and no tobacco harm reduction programs adopted for people who use drugs. Another change in Kyrgyzstan. In November 2025, the law was adopted banning vapes completely from July 1, 2025. Fine for an individual around $115. Our data shows that 33% of women used vaping to quit smoking. It worked. The pathway is now closed by law. IQOS, the only legal alternative, cost between $31 and $72, with an average income of $345 per month. That is about 21% of monthly budget. The option is not available on a permanent basis to women who use drugs who are unemployed. Why don't women seek help? Not one barrier, an entire stack. First, drug use stigma, fear of police, registration. Second, gender stigma, bad mother, immoral woman. Finally, reinforced shame, not support. Third, the stigma is smoking women, especially in Osh, where speaking about this openly is nearly impossible. Zhenya also represents the situation in Uzbekistan. It's similar, same in Osh, because they are bordering. On top of all this, poverty and the law. No affordable alternative, no trust in governmental services. Women, no one asks for help. They continue to smoke. And now, the important part, what we do not know. We do not know how many young women aged from 18 to 25 in Kyrgyzstan use synthetic new psychoactive substances and smoke. In our sample, 13 of 35 young women were in this age group, a significant share, but no representative data exist. We do not understand how methadone, alpha PVP, and other synthetic substances interact with nicotine addiction. Some synthetic substance and new psychoactive substances suppress the urge to smoke. Other dramatically amplify it. No systematic research exists. And also one quote from women who participate in our assessment. She told, after methadone, I don't feel like smoking at all. It just disappears. But with heroin or methadone, it's completely different. Then I start smoking strong cigarette to intensify the effects. Think about what this means. One substance suppresses to urge to smoke. Another amplifies it. The approach, just tell her to quiet, is completely meaningless without understanding what she is actually using. An interesting finding on NASWAI. 25.6% of men in our study use NASWAI. Among women, 0.5%. Why? Stigma. This is unknown. And finally, what works for women in OSH, where stigma is at its highest? We documented the gap. We don't have the answer yet. Despite all of these changes is possible. Our assessment ran its own pilot. 55 women, 3 months vapes plus trainings. The result of 3 months our work, minus 45% average reduction in cigarette smoked after access to vape. 60% changed their attitude towards smoking. 75% reduced consumption after cognitive behavior therapy and training, where participant 30 women. Three women completely quit combustible cigarettes and switched entry to vaping. What worked? 3 principles. First, peer-led model, not a clinic. Zhenya also told about this. Women don't go to doctor, they are afraid. People from community, they told that they are their own doctors. They don't listen people from medical structure. A peer counselor, their trust. The peer research, thus the system could not. Second is a cognitive behavior therapy plus a real tool, not lectures. Cognitive behavior therapy shifted the thinking. Vaping gave a concrete instrument. Without cognitive behavior therapy, vaping doesn't hold. Without vaping, cognitive behavior therapy stays theory. Together, result. Third, age-specific personalization. We run separate training for women aged 20 to 26 and 40 to 47. Younger women, reproductive health, risks, and hormonal context. Older women, hormonal changes and chronic illness. One program for everyone is not working. And also I want to share one quote. After the training, I realized I could manage stress without tobacco. That was an important discovery. Vaping can be not just a change of habit for me, but a way to regain control over my health. And the last slide. Let me close my presentation not with 3 recommendations, but with 3 questions recited at everyone in this room. First, if you work in harm reduction, when did you last ask your clients where they smoke? It takes just 30 seconds or maybe 1 minute, and it could start a conversation they have never had with anyone. Second, if you work in policy, the vape ban protected those who don't yet smoke. But what does it do to a woman who already smokes a pack a day or uses drugs? Is there an answer to that question in laws in different countries? If we are researchers or donors, young women using synthetic new psychoactive substances are the least studied group in Central Asia. Almost no data and no programs. Thank you.
Thank you very much, Alla. Striking data. What can we say? It is now my pleasure to introduce to you Любовь Воронцова.
Вы получаете данные и предоставляю слово госпоже Любовь Воронцова из Казахстана. Она активистка, и она является ключевым
efforts to help people with HIV and to fight for the rights of other vulnerable groups in the country. The floor is yours. You're welcome.
Thank you. Thank you for service for short people. Hi, and thank you for your passion. You know, I really appreciate my colleagues from Kyrgyzstan and Uzbekistan because we already know about the context, women, HIV, and drug using. And that's important. And in my presentation, I will try to keep the focus for actions and give you help. And first, it's a little bit numbers about Kazakhstan. I don't want to say about all numbers, but it looks like really similar that we saw in Evgenia's and Alla's presentation. And just one thing that I want to keep the focus to, the most of anti-tobacco campaign in Kazakhstan is focused to young people and general population. It's important that when I follow up in my presentation these things. Another thing, it's like the same. We have a lot of smokers. We have a lot of women who use tobacco in Kazakhstan. And yes, this is the numbers. And of course, first step that we should do when we want to do some action, we need to know about the needs women. And this is numbers that we do, how we did this, how we follow the needs and how we take this information in Kazakhstan. And the key funding was really the same that Alice Evgenia said. It's like it's all about it's all about the coping mechanism, fight of stress, and gender stigma. We all here in the same level with our neighbors. Yes. But I want to focus in the one main things that my colleagues already mentioned about information, about the safe places when women can take this information, where women can discuss it about their experience and how they can do some tobacco harm reduction, about this. And what we saw in our assessment, the women reported a lack of non-judgment communication and safe places to discuss smoking, stress, and quitting. This is important. And breaking the don't talk about this rule should become to one of responses to this problem for women. And this is how it's look, yes. It's like one of gaps. And what I want to share with you about how we started to do action. And you know, when we talk about community-led assessment, you know, community already started to did some actions when they started assessment. And of course, first step, it was education. Education with peer consultant. We used some online courses, yes, academic tobacco harm reduction, which was very useful for our peer consultant. I really recommended this. And second part, it's a face-to-face meeting where we're talking about the harm reduction approaches, gender-sensitive services, stigma, stress, and communication strategies for women living with HIV and for women who use drugs. And we also thought about the one of topic, very important topic about, for example, reproductive service. Nobody talked with women about this, when how Evgenia said it's like a taboo. Women who in pregnancy can be women who use tobacco, and this is like very important. Next part of education, it's like peer-to-peer support and consulting. Our peer consultant go to the women and women living with HIV and women who use drug in their cities, and facilitating safe discussion about smoking, stress, dependence, and harm reduction options. And next step, it's like we are development community-led information materials for these women, where they can take some information about harm reduction options. And this is like example how it looks like. We created some videos, materials about women experience, and we created the guide for women living with HIV, women who use drug, with simple rules how they can take some option, what they should do if they want to reduce their harm from tobacco using. And this approach successful because there was already an existing infrastructure of peer counseling working on HIV and harm reduction for people who use drugs. You know, we already have infrastructure. We just need to add another important question for these services. And that's why it's work really good for our women. Yes, and this is campaign based in materials, based in data collection from community-led monitoring of women. And this is important too. It's like an answer to questions that women give us in this assessment. Yes. Here is a small video, but we don't have a time for it. But the women in focus group share it with us, their experience. And now this is experience is like based on our information company. Yes. And what is the key takeaways? We should know. How my colleagues, my sister from Central Asia said, Women living with HIV and women who use drugs have a specific tobacco harm reduction needs. We saw that in this presentation, and this is very important. Smoking is closely linked to stress, stigma, and emotional coping. And peer-led, community-based approaches are the most trusted and acceptable way to discuss smoking, quitting, and harm reduction for women. And of course, HIV and harm reduction services can improve access to information, support, and healthier choices. And this is important, yes. Okay, I'm over. Thank you for your passion.
Thank you so much, Lyubov. So we have just heard that a lot of women are actually aware of the harmfulness of smoking. We don't need to tell them that. We need to create safe spaces and actual access to real treatment and real help with all the multiple issues that they have in their contexts. We will now take a couple of questions from the audience. So if anyone would like to ask our presenters, please do it now. Yes.
Yeah, I think the presentations were really very nice. It was driven by the data impacts, and it was kind of learning for me because this was something that was new. I have worked in HIV and TB, but the tobacco intersection with the people living with HIV was something very much new and learning. My question is that in India, it's a home of people who use drug or tobacco in different forms, right? In India, women who use drug or inject drug are forced to kind of, not forced actually, they are encouraged to take another alternative substance, like for example, opioid substitute therapy, OST, in the form of methadone or buprenorphine, right? But many community members in India, they think that if they want to quit the injecting part or the used drug part, then they should start smoking because that is the safest thing. And people in India, people who are in HIV response, the ultimate objective for them is to stop the transmission, right? So they also don't, like stop them to kind of, start smoking, but do something else. If not injecting, but then something else. So how, in that context, we as a community members or the network of the civil society can intervene and can provide that information is also important, which has never been talked or discussed. Is there any way that we can do something like this? Thank you.
Thank you for the question. Any thoughts about this?
I'm already answered to your question in my presentation. It's like for community, it's always important to have a place where they can safely talk about the experience without stigma and discrimination. And for example, in Kazakhstan, we created some chat for women. They can share about experience and learn each other how they can go to quitting or less harm from tobacco. And for example, one of our peer consultants, she is from Astana, and she was quitting the tobacco during our assessment, and she shared about and she followed from our guide. That's, for example, just break the rule, we can talk about it. Even in program harm reduction and drug user, we don't have any information about how it's harm. And what you say about the when I started to use drugs, I should start to smoking, and if I stop to using drugs for the same time and have a remission, I should stop the smoking, but I can't, and it makes stressed. Yes, And this is the same in our country that I heard you. It's like, this is like, I think we're all in first step. Just start to talk about that.
And for doing this, I would note that the already existing, very grounded infrastructure that you have created through the decades of your work helps a lot now with addressing tobacco issues in people. We had one more question here. You're welcome.
Actually, I have rather a comment as a question. I have to say that it was a great presentation. Thank you, Evgenia, Luba, and Awa. And my small question is actually, as you mentioned that the women in your countries are very, very stigmatized for the smoking. Is it the same by the men or not?
Yes, indeed. We are living in a patriarchal countries, and in Central Asia, it's specific. It's changed from Eastern Europe because of Islam religion. It's also women smoking. It's also depend on it, and it's became more and more in our countries. It's something. It's really depend on it, and yes, it's really about men. That women cannot smoke, they cannot use drugs, they cannot make something with their bodies, and etc. etc.
Thank you very much. We have now run out of time, unfortunately. I suggest we continue conversations during coffee breaks and further meetings today and the rest of the conference. I thank you all very much. We have heard just very striking and invaluable insights from the communities, and I do believe it will help us build meaningful, rights-based and context-related and gender-based activities for women who suffer most from multiple vulnerabilities in their lives. Thank you very, very much, and thanks for the audience for listening to us and supporting our presenters. Thanks a lot. See you soon after the coffee break. We are happy to see you. Well, yes, please take your seats. Enjoy the event. Okay. So let me remind you that we are having here the Global State of Tobacco Harm Reduction Roadshow, which is composed of two parts that represent communities of the most effective people who, in addition to other vulnerabilities they have, also smoke and use nicotine in other forms. In the first part, we talked about women who smoke, and now we are going to get insights from another group of people for whom smoking is really something that kills them literally more than other people in general population. Well, that will be our session about tuberculosis and smoking. And let me remind you that our session is live streamed and translated into Russian. And those participants watching us online can also use that translation and are welcome to put their questions and comments in a chat. And I hope that after this session, we will have time to answer your questions and address your comments. We are happy to have you with us. Our panel, first of all, consists of community activists, very prominent advocates in tuberculosis sphere. We are having now Cristina Rivera, representing not one country, but several, originally from Ukraine. We now have Aman Shukla from India, representing young people affected by tuberculosis. And we have Timur Abdullayev from Uzbekistan, representing all of the struggling people in this world, I think. a very prominent advocate with a proven history of advocacy success for the sake of people. Well, it is now my pleasure to introduce Cristina Rivera to you. She is a TB communications expert and TB advocate. Her work focuses on communication, stigma, community engagement, and making sure that the voices of people affected by tuberculosis are heard on all the levels, and their challenges are being discussed. Cristina, the floor is yours. You're welcome.
Thank you so much for such a great introduction. And I also wanted to add that I'm also a migrant health expert. I became after me moving to Germany after war in Ukraine. And today I will also mention that migrants also became a vulnerable population between tuberculosis and HIV and many other issues. So actually, when I was listening to other presentations, I get an idea to name my presentation Everything What You Want to Know About TB, but afraid to ask. But yeah, today we are speaking about TB and smoking, and this is a dangerous link. And I want to start off my TB experience, my TB journey, because I fell ill in TB in 2014 when war started. I guess it was because of the stress what I got from all of circumstances what I had. And 1 year I took 12 pills a day. I used to go to the hospital for 2 weeks, and I saw many people there who smoke
and I smoked as well. And of course, we were stigmatized from the doctors because nobody liked that, and it's supposed to be dangerous. But at that time, 12 years ago, we didn't hear nothing about safer nicotine products, and we used it to smoke like comprehensive cigarettes. And after my recovery, I became a TB activist because I saw how much stigma, how much discrimination people affected by TB faced. And this is how I became a TB advocate, and because I've used it to be a journalist before, I also start to work in communication, and it helps me a lot to see connections between different topics and go deeper to the problems, to find out how it could be, what kind of reason could be in this problem, and how to solve it, and how to encourage people to talk about their problems, to fight stigma, to fight discrimination. And actually, this is how to route me to tobacco harm reduction. So, and let's talk about tuberculosis itself. And actually, if you don't know that TB is one of the world's deadliest infection diseases, much more worse is HIV, and actually, according to the last WHO report from the last year, but it fits to the 2024, is that almost 11 million people fell ill with TB worldwide, and over 1.2 million people died from TB. And actually, not only people who get ill are affected by TB, because worldwide, 1.7 billion people have latent TB infection. It's about 1/4 of the world population. So those people have to be also careful to their health, and also public health needs to pay attention on it. And now we have also a new public health challenge. It's so-called multi-drug resistant tuberculosis. It's a form of TB that is resistant to at least to the most powerful first-line anti-TB drugs. It means isoniazid and rifampicin. And actually, this is a part of this global problem of this antimicrobial resistance. And actually, when scientist Zelman Waxman, actually he was born also in Ukraine territory. He invented streptomycin in 1934, and now this drug, this medicine streptomycin, doesn't work for tuberculosis at all because of the drug resistance, because actually this bacteria develop resistance to the drugs very quickly, and this is why tuberculosis is very dangerous. And actually, from 3 till 4% of all people with TB develop drug-resistant TB, multi-drug resistant TB, because of incorrect, incomplete, or interrupted treatment. And actually, now is a big problem is because drugs against MDR TB are more expensive. The treatment takes more longer, and actually, it could be also transferred from person to person. So, and what it has, also we have this connection with, what kind of connection with tobacco, with smoking, we will talk later about this. You will understand why I mentioned MDR-TB as well. And what we have to know about smoking and TB infected. People who smoke are twice as likely to get infected TB, develop TB disease, and die of TB. And actually, an estimated actually almost 18% of people affected by TB, and 15% of people who died from TB, they were impacted by smoking. And it means that from 1 till 2 million people per year people with TB are linked to smoking, and 150,000 people died because of that. And if we see the countries, top 10 countries of total TB burden with absolute numbers, they are the first 8 countries of this list are responsible responsible for 67% of the TB, all of the TB diseases globally. And you see that India, Indonesia, Philippines, China, Pakistan, it's the numbers, it's the countries where TB is prevalent with a high TB burden. And actually, if we add top 10 countries by total MDR TB burden, we also should add Russian Federation and Ukraine. Only the Democratic Republic of Congo and Myanmar are not in this list. So if we count 12 of the countries, how to say, with a high TB burden and with high MDR TB burden. So I made the map where you see that. And actually, if we make the map of absolute number of adult smokers with top 10 countries, and then I made this overlapping combined map. Also, it's only 2 countries or 3 countries. It means Brazil and States, and I cannot see it from here. So smoking only countries of Brazil, Turkey, Japan, and Egypt, and everything else is overlapped. Yeah, how to say? So it means that we clearly can see that high smoking burden are related to TB MDR burden. And we have to do something with that because tobacco harm reduction could be decision for that problem, especially in those countries. And actually, I want to mention about my experiences as migrant health experts, because I used to take part in 3 researches about barriers for the mobile populations to link it to healthcare. And actually, we see like a language and cultural barriers, legal status and fear of deportation, financial problems, limited knowledge of the healthcare system, discrimination and xenophobia, poor living conditions. And actually, all of those barriers increase stress and what makes smoking cessation harder. So as we know, the people smoke just to avoid their problems, just to make life easier. How it was mentioned already by the presentation, of the great presentations of my colleagues from Central Asia, that women are saying, and actually all of people who are now saying, I know that it kills me, but in that moment, it makes me feel better to smoke cigarettes. So, and now we have, do you know him? I put it in person just in case that if you forgot how Timur looks like. In this slide, I wanted to mention how, as a communication expert and us as a partners community, how we try to behave, to change behave of, actually here are example of us to try to change donor behavior according to problems from a TB community. And we made several information campaigns to try to put up problems with TB, because as we know, I don't know, probably you don't know, but our community knows very well that on top is problems with the people living with HIV and TB. Despite to be the world deadliest disease is behind all of that. And we made a lot of campaigns, and because of the Timur great voice, now the topic of the TB is, I would not say it on the top, but it's mostly equal with, with topics about HIV, and also it goes more and more, it pays more and more attention, not only from the governments and donors, but also from the people, from the general population of the topic of the TB, because of course, it's a lot of stigma, a lot of discrimination, and actually a lot of misunderstanding from general population about this topic, about TB. And actually, if we look broader, is the same as we have now about tobacco harm reduction. And because of that, yeah, we developed a few social media channels, and we invite you to join us. We want to raise our voice about this connection between TB, between tuberculosis, smoking, and harm reduction. And here you could like our Facebook page and to see any news about our project, and to see more, to raise awareness about tobacco harm reduction, and to see a deep connection between TB and smoking. And actually we have Facebook group where you could start a discussion or join our discussion, and to have a knowledge exchange and promote evidence-based messages on tobacco harm reduction, etc. And actually, we would like you to help us to mobilize public and policy support, because as we know, we have already experienced that if you talk louder, then there's more chances that people who make decisions, people who need that to quit smoking, to use safer nicotine products, that they will get this information easier. Actually, we have also LinkedIn. It's more for professional discussion and linkage, and to connect people in this area, in this branch. And also we made YouTube platform where Timur will make his great podcast. He's a little bit surprised, but yeah. We already put videos from previous project, and actually it was about connection, about connection from HIV, mental health, and tobacco harm reduction. And if you want to know more about it, so welcome to our YouTube channel, and we promise to have a lot of more of information. So thank you very much. You feel free to connect me if you need, and thank you all. Thank you, Tatiana.
Thank you. Thank you very much, Christina. We now know the scale of the problem, but also we know how much communication means and how advocacy works. I mean, 54% price decrease for bedaquiline. You are super, guys. I mean, I can imagine how many lives were saved in low, middle income countries because of that, because this is very important. Now we are moving towards, and it is my real pleasure to introduce to you the youth perspective of Aman Shukla from India. Aman is actually the leader of the Unite Global Organizations for TB affected people. We are very happy to have you here, Aman. The floor is yours.
Thank you so much for that introduction. And my name is Aman Shukla, and I'm based in India. And I belong to LGBTI community, which makes us vulnerable to all the health services, delivery, and for any kind of services that we want to take. And as Tatiana said, that I'm also the founder and I lead a youth-led network on TB advocacy, and I'm the board member of Stop TB Partnership, representing key and vulnerable population. And this is a very good opportunity for me to kind of highlight the youth perspective, because always in this discussion of tobacco and any health challenges, young people are left behind. They have never included into the discussion. And what kind of future we are building? Because future is youth. You know, by 2030, young people from 18 to 30, we will see that more than 1 billion young people will enter into adulthood. And this adulthood is very much vulnerable. Why? Because this is the time when they will be influenced to the smoking. They will be exposed to other factors that impacts their health, right? Today, when I attended the first session on women living with HIV and drug impacts, tobacco impact on their health, that something kind of opened up my thought process, because this is just not a discussion, but it is something that we need to take an action together, because we are walking and doing things in silos. We need to come together and work collaboratively. Tobacco remains one of the leading preventable cause of death globally. Of course, we know that, but still we are not doing anything, right? Or we are doing it. Yes? Oh, I can't hear. That is what I think we are not doing anything enough. Yes. And of course. Repeat the question. Okay. Tobacco remains one of the leading preventable cause of death globally. Yes. Are we doing anything? No. No. Why? Because we are not working together. We are not working together with the people that are really working. And at the same time, if we see tuberculosis, in Christina's presentation, you must have seen a big numbers. 1.2 million people died of TB. 10 million people were notified with the TB. These are just not numbers. These are the people. They can be your friends, your colleagues, your children, your husband, your mother, your father. We have never thought of looking at this number from the perspective of our known, but we have seen them as numbers. Okay, 1.2 million people died. That's okay. I think we are still working on it. No. TB is the world's deadliest infectious disease, and that is impacting And in the TB community itself, we have a global TB plan, and it clearly says that people who are consuming tobacco are at a high risk of having tuberculosis. We have the evidence, we have written it in many places, but still we're not working together. I think this platform provides that opportunity for us to collaborate and work together. Yet, young people are rarely included into the discussion. And with this presentation and the session, I want that young people should be included into the tobacco response. Why I have written in tobacco control? Because you understand that we don't want tobacco control, but we want a tobacco response. We don't want to emphasize people to be controlled, but we want them to provide the options, the choice of the thing that they want and they are comfortable with, right? Yes. We don't want to control them, right? Are you all here want to be controlled by anything? No. We want the choices and options that we want to pursue and want to go ahead with it. And we should focus on harm reduction, because in tobacco itself, in many countries, we have seen harm reduction is seen something like illegal. But we don't want illegal things. Harm reduction means providing options and choices to the people who doesn't want to quit or they can't quit. And TB prevention and community health policies. So the future of TB elimination depends on the choices of young people make today. What kind of things that we want to see? What is the perspective when it comes to tobacco and TB together? It has a hidden link. 1.2 million people died in 2024. Do we know how many people out of them died because of smoking? No. We do not have the evidence that means. Also, it has a lot of hidden links. Increasing risk of TB infection, increasing the progression from latent TB to active TB. We all sitting in the room has a TB, which is called as latent TB. And if your vulnerability increases and immunity system comes down, you might get TB. Delay in recovery. When a person is excessively is taking tobacco, consuming tobacco or smoking, in specifically, they are delaying in recovering. Be it they are living with HIV, be it they are with the TB, or be it with any kind of disease that they are living with. Reduces treatment effectiveness, because it is not, when you are smoking, in a way it is impacting your health. And because of that, the outcome of the health is reduced and not effective, and increases the mortality. What about for people who are TB affected? For them, it is more dangerous. Why? Because they have a poor lung health. Why? Because they have an increased household exposure, greater financial burden, and intergenerational health consequences. So, TB requires tobacco prevention. If we want to see that we want to end TB, then we have to be smoke-free. And for that, we all have to think about working together. And not just controlling, but providing the choices and the options for the people. Youth are in the center of this challenge. I know this can be a hypothetical things that you say, oh, what are you saying? This is not really truth. But you will have to involve more and more young people so that you can understand what exactly it is. So why focus on young people? Because today's youth are exposed to social media, are exposed to influencers culture, are having a peer pressure, are having a mental stress, and easy access to information which are correct and which are misinformation as well. And the vulnerability of coping up with these skills is not there, right? When we see the reality is very much simple. The young people often begin nicotine use long before understanding its long-term lung health or health implications, because they do not have the information. The information have not reached to them so that they can be prevented from those things. Or if they have started, how to control, or how to be less harmful for the health. Why young people start this? It's very obvious, why young people start this, because there is no theory or there is no lecture in the college or school or in the community that, hey, you have cleared your 12th standard, now you should start smoking. Or it does not allow you are 18 years, now you should start smoking. No, it is all the social or culture that influences them. It can be a common desire for belongingness. When a young person newly starts working in an organization, in an corporate, in an college, they want to fit into that culture. They want to fit into that team. And if that team is smoking and they have gone to a smoking break, they get influenced because they want to fit into that culture. Curiosity to understand what happens exactly with the smoking, because my friend is smoking and he's relaxed and calmed after that. Does that help? Social acceptance. You want to be included into the community. You want to be included into that team that you are smoking. When I went outside in the break, I saw some beautiful girls making group and smoking there. I thought I should go into that group, but then I was like, oh, they are in the team because they're smoking. I don't know if I don't smoke, I will be able to fit into that or not. So that kind of curiosity and understanding that brings in makes people influenced to start smoking, or because they want to fit in. And stress management, online influences, perspective of reduced risk, because most of the young people who are also in the colleges, if you are interacting with the people who inject drug, they think that if we want to stop this, they know that injecting drug is a problematic and harmful for their health, so they opt for smoking. That perspective is also dangerous because they don't know the information, they don't have the options, they don't have the choices to choose. Or if they have it, it's very expensive. Can young people afford to take something which is expensive? No, because they're not earning. They're dependent on their family, they're dependent on the scholarship they have been provided, they have been dependent on some things. So the common reality is many young people face unemployment, mental health challenges, social exclusion. For example, many students who are preparing for their engineering or for medical MBBS or some kind of common entrance exam, they are stressed. Spend long hours in studying, coaching centers and in libraries, right? Some begin smoking using nicotine products, believing it will help them stay awake, concentrate, or cope up with stress. What starts as an occasional habit can become dependence. And that is a problem. This is an example where one of my friends who was pursuing UPSC. UPSC is the highest level of examination in India to become a bureaucrat or IPS, IAS officer. It's a high-paying job for an individual. To apply for that, to appear for that, the individual used to use nicotine in such a way that he got addicted to that. And it did not even help to clear his exam, but then it also impacted his career. It's just not helping in one way, but it is destroying in other ways as well. And discrimination, because you're smoking. That happens a lot of time, right? But they don't know how to quit that. These factors shape in health behavior. The TB, if you see the TB perspective, What happens when tobacco meets TB? Among TB affected population, recovery becomes more difficult. Lungs damage increases. Household exposure rises. Treatment adherence may decline, and long-term health implications starts. For young people living with or is TB affected household, second-hand smoke exposure is a big problem. If at all I'm not even smoking, but because of that I might impact into my health. Increased respiratory vulnerability and normalizing of smoking behavior. Youth, when we talk about young people, it should not be something traditional. It has to be a smarter way. Because it's in history that people are evolving from telephone to mobile to some other technologies. In the same way, young people and the generations are evolving with the information, right? So what doesn't work for us is fear-based messaging. If I have to give an example of fear-based messaging, is that smoking kills people. That's an old message now. You have to come up with something new. The message that used to work for people is not working for us now. Shaming people who smoke doesn't work. Ignoring mental health, reason can be multiple. It's just not, ignoring mental health is just not can be smoking, but it can be multiple things. But to cope up those things and to understand that with empathy and dignity is important. Because we need dignity and empathy. One size fit all campaign doesn't work, right? The t-shirt that I wear or the shirt which I'm wearing will not fit to my colleague here. It has to be customized as per what they want. For example, many young people already know smoking is harmful. Knowledge alone is not enough. If we want effective prevention, we must understand the social realities, why they are. Pressures, aspiration that influence young people's decision. A message for 50-year-old adult smoker maybe it won't resonate with the 19-year-old young person. It has to be customized. It has to be focused based. It has to be target intervention when it comes to smoking and we want to reduce harm. What works for us is peer education. If a person like me goes in a young people's community or in the college or university talking about the issues or spreading an awareness or talking about harm reduction, it might change. It might bring an impact. There can be something that can be improved. Community engagement. I think when I see in TB community, I think we have a lot of communities, but the engagement is taking a pace. It's not as how it used to be in HIV, because I come from HIV background. I used to work in HIV program, and then I came to TB program, and I understood, oh my God, community engagement, network building, awareness, and this stuff is not there. Entire thing is medicalized. And I understand the same thing for tobacco. I don't see any community in tobacco talking about harm reduction, because it is already, struggling between some other community to this community. And then youth-friendly communication in the form of Gen Z. It is a time of Gen Z, It have to be something youthful. It cannot be. We cannot use the same thing that we used to use 10 years back or 20 years back. Now it's 2026, and we have to make it sexy. I know tobacco is not sexy, but it's harmful. But we have to make it sexy. Digital awareness and positive role model to empower their lives. In TB community, we usually use people who have been affected or are TB survivors to motivate, encourage other people with the TB to complete their treatment, to make them resilient, empowered in the TB community. We share the stories. That is also missing in tobacco. I think we could bring that in the form of young people talking about it, or maybe adults are talking about it. That brings a change. We must meet young people where they are, not the place where we want to bring them. Right? Ensure the access to accurate, evidence-based information on nicotine product and their health impacts are available on each and every platform that they are on, like social media. In HIV program, when we wanted to increase the demand for HIV treatment, we started using the dating application, Tinder and Bumble. I'm sure many of us will be on Tinder and Bumble here. And from that perspective, we started increasing the HIV testing. Why not for tobacco? Empower young people to make informed decisions through comprehensive health education and awareness, because that is also something which is not there. Because as soon as tobacco comes in, people start saying, no, don't come into this space. This is harmful. I know this is harmful, but you have to bring something coping up which can support them. Reduce the risk of increased and unregulated and black market product through appropriate regulation and public awareness. I feel a little concerning that, when we say vaping, in my country, in India, vaping is banned, but smoking is not. We have billions of people earning billions of money in dollars, but and killing people, but we do not have anything in alternative that can reduce the harm of a people who want to smoke or using tobacco. I think that need to be looked upon, the community that are there. Since we do not have the community, they cannot voice out to the government saying that, we need something to be regulated. Not all tobaccos are, less harmful. Not everything. We need to bring something to regulate in tobacco, right? Because we cannot ask a smoker to say, tomorrow onwards, you have to quit smoking. That approach is not going to work. We have to say that there is an alternative things. There are the other products, nicotine replacement therapies are there, and many more. There are many multiple things that we can come up. If we start thinking, we will come up with more options. But we have to start thinking and taking an action. Like how the organization's name is, Knowledge, Action, Change. We have to have a knowledge, then action, and then the change will come in automatically. So we have to meaningfully engage young people into this process as well, for the policy, advocacy, decision-making processes that affects their health. Because, in India, not just in India, but globally also, if we see, there are billion people who are young and their healths are impacting. And if they are not included into the discussion, then we are leaving a big chunk of population behind. And that is a big problem. And we won't be able to finish that thing, tobacco-free world. We won't be able to see that, ever. And foster intergenerational leadership by creating opportunities for mentorship, knowledge transfer, and youth leadership development. With this, what I mean is that I have two mentors sitting here in the room. Chief Faustin is here and Timur is here. They helped me to set up the youth network, Unite Global. And with their mentorship, they are helping me to understand the TB landscape, how to work, how to cope up with the people, how we can lead into the TB response. And that is why I'm here, frankly speaking. Otherwise, I don't think so I would have been able to present the PPT. In the same way, we have to bring young people into the response, build them, mentor them, and then transition. We're not saying, you go out of this program. We are here. No, we cannot expect that to be done. Of course, we don't know anything. We are learning and contributing. So build sustainable movement by preparing the next generation of leaders to continue advancing public health and communities. And why youth leadership matters? is because lead community awareness, we can do the design for harm reduction campaigns, influence policies in the country at the regional level, in the national level, or at the global level, challenge misinformation, because you see a lot of people on TikTok, Instagram, flaunting their, beautiful bodies and handsome people with the informations, and that attracts. I've seen 1 million people looking at one reel of 30 seconds. 1 million people. Wow. That's the power of social media and young people who can influence and who can spread the awareness and mobilize communities. And as I said, positive storytelling is something which is very much important, and we need that here as well. So I represent Unite Global. It's an infrastructure of young people's platform, where and it's a youth-led global platform which talks about TB, community engagement, youth engagement, mobilization, advocacy. And we have a 4-pillar how we work into this is advocacy of inclusion young people into the decision making, and mobilization of young people, engaging them into the TB response, and building the capacity to lead the process and into the TB response. Our vision is very much simple: a world free from TB. And we will be able to see a world free from TB if we are smoke free. And that is why I am here. And this is my contact number, and I'm done with my presentation. Thank you so much.
Thank you very much, Eman. It was just brilliant. I can't say anymore. It was just brilliant. Thank you very much. We've heard very interesting, and we really needed to hear that youth perspective. This is the first time here at GSTHR roadshows that we hear the perspective of TB-affected people, and we have just heard very valuable insights from young people perspective. Thank you very much. And now it is my honor to introduce to you Timur Abdullayev from Uzbekistan. Timur is the fighter, I would say, one of the most known figures in TB community, with a proven record of achievements for the benefit of people affected by TB. Timur, the floor is yours, of course.
I thought you would go on for like another 5 minutes introducing me, but thank you. So good afternoon, everybody. So my presentation is about this consensus statement, which was by now supposed to already be published. Unfortunately, this didn't happen. Partly it's my fault, partly it's not, because the thing is, over the last few weeks, it turned out that the sect of, oh no, THR cannot be happening, also known as the Bloomberg sect, also known as the WHO position sect, they seem to have already infected the TB community as well, unfortunately. I didn't expect that, to be honest. So in TB community, we have always been aligned that we care about human life, that we care about human rights, that we care about people-centered approaches. In TB, we moved from TB control to TB response. From basically, okay, you take these drugs and you shut up, to, okay, first we counsel, then we give treatment, and we give different options of treatment, and the person doesn't need to come to clinic every day, because that was the reality for people with TB for years, especially in this region. In Africa, this approach was implemented differently, but in this region, if you have TB, first you go to the hospital, then you come to the TB clinic every day. And once again, I'm sorry to say that, but WHO was not helpful, because WHO said that people are not supposed to have days off for TB treatment. And by demanding that treatment is directly observed, they basically made it mandatory for people to come to the clinic, and you know what? Clinics don't work on Sundays. And WHO was somehow like kind of blind to that fact for years. They knew that you cannot skip days on TB treatment. They knew that TB clinics don't work on Sundays, and they were still fine. And this is where we are coming from. It's been a decade since we were trying to transition to people-centered care for TB, and we're not yet there. So this is the legacy that WHO sometimes leaves. And in tobacco, same story. WHO develops the framework convention, includes tobacco harm reduction into tobacco control, and then forgets about it. And WHO somehow starts positioning tobacco harm reduction as a thing that doesn't help tobacco control. I am afraid, Aman, that the youth of today will think that adults are dumb. Because how can a sensible person do that? My thinking is probably it's all money. I don't know what happened to Mr. Bloomberg, why he believed that tobacco control without tobacco harm reduction is the way forward. But money can do a lot of things. Money can go far. So somehow we have a lot of people taking that side and thinking that this is the way forward. So a few weeks ago, a couple of months ago actually, we decided that we need to somehow formulate a consensus. And this consensus is not just coming from TB. It is coming from TB and HIV. And there are reasons for that. I hope it is going to work. Yes. So this is who we are, right? People living with HIV, people affected by TB, and key and vulnerable populations. I will not describe like what is here, but basically what matters is this. This is why we want tobacco harm reduction. People affected by TB, for instance, they face double risk of TB infection. People who smoke are facing double risk of getting infected with TB. For those who are infected with TB, they face a double risk of progressing to a TB disease. And for those who have TB disease, they have a double risk of dying of TB. This is the reality in tuberculosis. And the reality in HIV is that you're more likely to die of smoking than to die of HIV. And this says something, right? And there are some other facts why we think that people living with HIV and people affected by TB are actually best positioned to change that, to challenge the position of WHO and to challenge the current state, the status quo, and demand tobacco harm reduction as part of HIV and TB responses. I will not spend a lot of time on the slides. They are available. If you want, you can also ask and I will share. But I think it's actually, it's there, so you will be able to check. Now, what happened a few weeks ago is that we agreed that the problem is there, and we need to do something about it. And then something happened which is not on this slide. A very dear colleague of mine, a person who I respect a lot, he made a Facebook post. And he wrote that basically tobacco harm reduction is bullshit, that it's against WHO policy, and there are people who think that WHO policy is the fact, which is nonsense. And that he would rather take money from Bloomberg than from tobacco industry, suggesting that anything about THR is tobacco money. And then he had me really pissed off. And that's how the conversation started. We started commenting on the post. I wasn't the only one. But I was also chatting to him in private, and eventually he actually accepted that maybe he might have been wrong. So there was another post where he slightly changed his tone. Nevertheless, he still continued. He reaffirmed that he believes that, WHO is the science, and the science has to be followed, which isn't the case. Okay? And if you have ever seen, and I think you have, the WHO position on tobacco control and tobacco harm reduction, it's as far from science as I am far from ballet. Okay? So it's like very far. There is no science in that position. There is no science in that position. It's just straightforward BS. So we discussed this later on with colleagues, with friends, and we thought that, okay, we need a consensus. We need to agree. Because as I was talking to this colleague of mine, he was actually, he's not brainwashed, he's not stupid, so he understands arguments, right? He has this kind of brain which is like, okay, let's see what the reality is. And the conversation continues. So I really hope that he will continue discussing this. And hopefully at some point, actually, people will recognize that WHO is not always led by science. I wish it was. So we discussed this. We agreed that we need a consensus, and we started laying it out. Unfortunately, that's where the process got delayed, because we reviewed the evidence. The evidence is quite strong. But then we started drafting, and there were some basically questions that we had to answer. First of all, we wanted the position, the consensus, to be endorsed by community networks of people living with HIV and of people affected by TB. And it looks like we can't, because organizations, including community networks, they are not ready to say, yes, we support THR, yes, we disagree with WHO, to our regret. And some of them actually apparently they are brainwashed. So we decided that instead we will make this consensus led by people and endorsed by people, not by organizations. And when at some point organizations are ready, they will join. So that was the shift from like who the consensus is coming from. Another change was where the consensus is coming from. Because initially it was just colleagues from Eastern Europe and Central Asia. And then when Aman decided he doesn't want to be positioned as Eastern Europe and Central Asia, we decided, okay, we will make it global because of Aman. No, it's not because of that. It's because we started getting more and more people from outside of the region. And the thing is, after all, when you will finally see the consensus, and hopefully that's going to happen within a week, you will actually see that everything there is quite applicable globally. So there was just no point of making this very region specific. So that's how the consensus changed from Eastern Europe and Central Asia to like global. And there were some other changes, but now finally it's very close to being finalized. So hopefully very soon we will launch it. The drafting was complicated, a lot of back and forth. There is just too much to put there. The consensus now is 6 pages long. You don't like reading 6-page long documents, right? Unless you work in WHO. So, and I don't know how to make it shorter. Actually, I found a way how to make it shorter. It's just not going to be appreciated by the people with bad eyesight. Tiny font? Looks like it's not going to be helping. But anyway, believe me, it's 6 pages. It's a lot. But it's pure gold. It's just, and I'm not using diamonds. Diamonds are overvalued, but gold is now, is the thing as currencies collapse and the currency market is volatile. So yeah, it is actually a very congested representation of what we know and also emphasizing what we don't know and we need to know. So for instance, and let me, okay, it worked. So what's in the consensus? First of all, it starts with a preamble, why it's important, right? Who we are, people living with HIV, people affected by TB. By the way, person living with HIV here, twice a TB survivor here. So maybe that's why I'm so angry. So then we just say like, okay, this is why it matters for people living with HIV. This is why it matters for people affected by TB and for key and vulnerable populations, which is why we're doing this. We show the evidence, and then we basically just address, I wouldn't say attack, we address the position, the WHO position, and I would say expose it, because whoever with brains starts reading the WHO position will immediately want to expose it. It's just so well written. And finally, it's our demands, what we want. And I think these are the demands, yeah. So what we want is to end the taboo. I don't know who was so smart in WHO who decided that THR, tobacco harm reduction, is not just not part of tobacco control, but is also should not be part of tobacco control. And I don't mind, by the way, I don't mind if WHO wants to call it tobacco control, let them call it this way. Just make sure that tobacco control is more like tobacco response, as Aman said. It has to be responding to tobacco. Controlling tobacco, good luck. You control TB, you failed. And when I say you, I don't mean you guys. I mean WHO. So we want a risk proportionate regulation. I know it's insane to ask for a risk proportionate regulation, like we never did that and now we will do. But that's what we need. To be honest, I'm tired of hearing this coming from quite smart people saying that we just want to substitute one harm with another. And some of these people work in drug harm reduction. Can you imagine? That's the level of insanity that is going on. And then we want to integrate tobacco harm reduction, and not just tobacco harm reduction, but tobacco response, into HIV and TB responses. There are just way too many smokers in these two communities, in the communities of people living with HIV and communities of people affected by TB. So we can't ignore it. I was actually quite excited that, like, okay, one more area that was ignored for years until I came. I'm very humble, yeah. And yeah, but that's the thing that we need to do, and we also need to guarantee community participation. It's ridiculous, 21st century, and the Framework Convention, the Secretariat, there is just no proper community engagement, period. As far as I know, there are NGOs involved. More than half of them are paid by Bloomberg, and therefore they're part of the sect. And but for them, we are part of the sect. You know why? Because automatically we're doing THR, therefore we are paid by tobacco. Anyway. And there has to be donor funding transparency. That's another demand. We want to know who funds those people who do not even bother to speak about evidence and just straightforward accuse THR of being so bad. We want to know where they get their money. If they get money from Bloomberg, okay, at least everybody will know. And I'm pretty sure that's not going to be just civil society people. It's going to be researchers, it's going to be policymakers, it's going to be WHO consultants. So these are the demands, pretty basic, but try to ignore them and then you will have to deal with some crazy people. Now, next steps with the consensus. We finalize it, we publish it, we open it for endorsements, and we hope that you will put the signature. Even though we position it as a statement, as a consensus coming from people living with HIV, people affected by TB and key and vulnerable populations, nobody will be checking if you are. For instance, you, sir, you look very intelligent and important. You will be able to sign and nobody will ask like, oh, do you have TB or you had HIV or you are a key and vulnerable population? Nobody will do that, sir. Nobody. So you can sign. It's okay. So we hope that this consensus will actually go to the Conference of Parties. We will make sure WHO is aware. We will make sure WHO is not just aware, but can't ignore. I feel that we do have, like, when I say WHO here, it doesn't mean I think the entire organization is just a pile of crap. No. And there are some parts of WHO which are much more advanced. For instance, we have what we used to have, the Global TB Program in WHO. Now it's called differently. It's now called Department for HIV, Tuberculosis, Hepatitis, and Sexually Transmitted Infections. So they expanded the mandate. Fine, it's still the same good people, sensible people. So we really hope that actually WHO will be on our side fighting with WHO. Yeah, WHO is a hydra with many heads. So yeah, some heads disagree with each other. So let them talk. So far it wasn't happening, so hopefully it will. And yeah, we eventually expect, not hope, we expect WHO to change its position. Because sometimes when you call someone on their bullshit, they can't hide it anymore. They have to do something about it. So that's what we hope to achieve. And so I'm done with my presentation. Thank you very much. But before we go to questions and answers, I actually want to invite this distinguished gentleman sitting on the front row to please join me. This is the Vice Chair of the Stop TB Partnership Board, Chief Austin Arinze Obiefuna. And I would like you, sir, to share some thoughts.
Thank you.
Thank you so much.
Hello, everyone. Thank you for having me here today. I mean, this came at the very last moment, and I'm always pleased to speak, especially when it comes to such an initiative. I want to start by saying that distinguished colleagues, communities, because I mean, in this room, we don't have to wear masks or try to speak with filter. We should speak without filter and express ourselves the way it's supposed to be. Obviously, if you listen to all the speakers, there is one key thing that is coming, that we cannot end TB without ensuring that we do more around tobacco or smoking use. We need to really, really integrate those services, not just within TB and HIV, but within the entire broad health system. It is very important because often at times we usually do this in silos, and it makes it more difficult even, to have clarity, audience. And I want to say that we shouldn't always depend on WHO in all this, because they also have competing priorities as well. Their priorities are so many that they might not be able to, look at every diseases or every interventions that are coming out. But we should focus more on building evidence. We should work together. We shouldn't work in silos. We should work together. And even the new language that is coming from huge global financing agencies like the Global Fund is actually speaking about integration. And I think this is the best time for us to be able to come in with our interventions, to integrate harm reduction and into the entire broader health system. We look at, in the past, when we talk about abstinence, when it came to HIV, it never worked. It never worked. I'm not looking at a perfect language that suits everything, but I'm looking at comprehensive intervention that can touch every little thing. I know Aman, when Aman was speaking, actually talked about the youth are actually the future. We need to, it's one of, we are the youth in this room anyway. Aman and I, at least we want to see the future of ending TB in our lifetime. The reason why I mentioned Aman is that I think if we should be truthful to ourselves, somehow every one of us have tried something, maybe cigarette, weed, or something, smoking. Maybe, but it's probably only you that haven't really tried one of those. So we should be able to speak from experience. I mean, there's no way we can continue, even from the continent where I'm coming from. I'm from Nigeria, but I work from Ghana, Africa, I mean, globally, everywhere. So I understand some of the interventions around tobacco harm reduction in these countries. And I can tell you, there is no real specific regulations that push, for such integration. Maybe probably Nigeria have something stronger around it, but it's all around advocacy and community interventions. There is no strong policies. There is no strong financing. And most of the times it's actually seen as a standalone activity, which makes it even more difficult to be able to engage. So, I mean, as we are in this room, I know we are all converted people. We need to also find a way to propagate this message outside this room and to let people know that we have alternative solutions. It's not just about stop smoking. It's about having alternative way of helping people who are already addicted, who are already into it, to find a way probably to reduce. We all know that, yes, there are a lot of evidence that shows that smoking and connection with tuberculosis has a lot in terms of the treatment. It can affect treatment of TB. It can affect, like the Timur said, it can also, for people who have a TB infection, it can actually help progress to TB disease. And people who already have the TB, this can actually lead to death. And I see it as neglect from our own part if we are not speaking more about how we can integrate our intervention within the broader health system. We should not try to sit on our own to have these conversations within this room just ourselves. We should expand it. So my will be to engage more at country level. Let's help, because sometimes you might think that the program actually understands what to do. I'm not quite sure they really understand how to create policies that will help for the integration of tobacco harm reduction within their programs, like the TB program, and the HIV program, and the rest. We should be able to, as we are identifying these problems, we should also probably provide some kind of solution on how they can create policies. We already have the evidence are there, and we are still building the evidence around. Let's work together. Whatever is happening over here, it's not different from what is happening in Africa or in Asia. It's all the same thing, depending on the context, but it's almost this, it's just the same. So in terms of learning from each other is very important. I'm happy that I'm actually here. It's my first time attending this meeting, but I can tell you that I have learned a lot. I've really learned a lot, especially from the first section. When we talk about TB, it's like they call me TB man, so I know a lot around TB, and also I've read so much, TB and tobacco. So it's something that when I was invited, I said, wow, this is a very important meeting, an opportunity for me to come here and speak. I'm supposed to be in the US now discussing the pandemic preparedness response, but this is a very important meeting, and we should not stop here. We should continue the conversation. People should, I listened to Aman's presentation. It's like something that we really need to show to parliamentarians, show to policymakers, to make sure that when they are speaking in their corners, they can be able to, also alert some of these interventions. On that note, I want to stop here, but I want to tell you that do not lose hope. You know, advocacy is not an event of a day. It's something that is a process. So we keep doing it until we get the desired outcome that we want. So on that note, let me say thank you to everyone, and thank you to our wonderful panelists and our moderator. Thank you.
Thank you very much, Chief Austin, for your message. And we're extremely happy to have this truly global representation of perspectives and views here at this panel. Now, thank you, Timur, for all your effort that you have already put in the consensus paper that I have read. And we will make sure to help you to disseminate it and gather more and more signatures and supporters. Now we will open the floor to some questions, both from the audience here and from online, and my colleagues will help me see the questions from the online if we have some. You're welcome to ask your questions. Yes, Julia, please.
Yes, so hello, dear colleagues. My name is Yulia Kalancha. I'm from the TB Europe Coalition. And thank you very much for the presentations. I really like the point that youth prevention should not be fear-based, shaming, or one-size-fits-all, and that young people needs to be meaningfully engaged. And coming from the TB field, this discussion is very relevant for us because people who smoke are a group of increased risk of TB and poor with TB outcomes. So for us, tobacco harm reduction is not an abstract debate. It is about the practical, non-judgment support for people who already smoke, including those who are not able to quit immediately. At the same time, in tobacco control, youth protection is often used as the strongest argument against even discussing the alternative nicotine tools, that such discussion may be perceived as a product promotion and may create risk for young people. So my question is, how do we can create a false choice between protecting young people and have an honest, evidence-based conversation about harm reduction for adults who already smoke? And more broadly, do you think that we sometimes speaking about young people rather than with them on defining what the prevention should look like? And maybe what strong use words can change the status quo in this debate? Thank you.
I'll keep it very short of 30 minutes. Okay, I think when we talk about young people, so designing something for them, it should be with them. Okay, I've seen many discussions in the program implementation where young people are never involved, but there are adults who decide on their behalf. So in order to kind of bring them or engage them, a lot of implementers and the stakeholders says we do not have young people who have enough information about this. The solution is that you bring them afresh, build their capacity, mentor them, and let them lead. You will not get anyone, oh, okay, that person looks very intelligent, bring them here. And he will be talking about TB or the tobacco. You need to provide the space, engage with them, engage more people like them, and then you will be able to see some impact into that, for sure. And when it comes to the protecting young people from preventing it, I think the best thing that we can see, we can talk about is awareness, because we do not have enough information that young people can take a decision. And young people, we all know young people are always vulnerable to these kind of things. How they can be protected? Information and without discrimination, providing the options and the choices that they want. The third thing that we can ensure is, I know the smoking is very much harmful, but providing them something which is less harmful, and slowly, slowly making it reduction to not, addicted to the substance. This is what I have to say into this. Thank you.
Thank you very much, Aman. More questions? Yes, you're welcome.
Hello, my name is Marianna Iwulska. I am chairperson of European Network of People Who Use Drugs. And I have maybe not question, but a comment that this opposition against substitution for nicotine is such a similar like substitution for drugs, which we've seen and we still have. It's like, it's remind me this ideological, not science-based approach, which is still pushing in. And I am astonished that this is still going on. And I think that maybe bringing people who are like get better because of substitution is some kind of approach. Like I am 26 years on methadone substitution, and like I am going like a proof to show that it's working. So maybe people who get better thanks to nicotine substitution can be a proof to some these questions. Thank you.
Thank you very much, Mariana. So yeah, that's what we are doing here today, bringing lived experience to persuade other people who lack information, as Evan said, to persuade it from our personal perspectives, to share how we survived something, how we feel better because we do not smoke and because our health rights have not been violated at the same time. Do we have any questions from online? No? Not yet. Okay. Anyone else with your questions or comments in the audience? No more questions. Yeah, because, I mean, the content of this session was so brilliant and so interesting. Thank you very much to our presenters. Thank you very much to Chief Hosting. You've made a long trip to get here to see us. We are very glad to meet you. And let's continue this conversation and discussion during the lunch and further GFN program this week. Thank you very much for your support, all people that present here. It is very important that you, whatever you do, whether you are a policymaker, a doctor, or you are working in a multilateral organization, please support communities, because you see they are so very brilliant. They do very, very hard work with diverse people, and they do need support in their work. Well, we make sure that we do everything we can for you. And yes, I'm happy to give a microphone for your final words.
Actually, I wanted to mention that probably we didn't recognize it yet, but today was a really historical moment because of your statement, because I know you, Timur, it's beginning of something very important. It doesn't look like that is what we required, but we should remember that for the next few years it will be spread broadly and it will change something. It was a kind of milestone, I guess.
I just want to say that I know this was an historical moment, I agree. And this was the first time where we are talking about TB and tobacco. And it should not be the session end, but this should be a conversation that we start from here. And we start and we do something. As as Timur also said, there will be some documents released. We want you all to support us in consensus. Mobilize more your friends, colleagues, and other stakeholders to support that. Because if we are successful in doing that, we will be able to do more and brilliant work together. Thank you.
Very quickly, yes, I think it is the first time we are speaking publicly on behalf of TB community at a conference, because we did have some road shows before, but this is the first time we appear in the conference, and hopefully, by the end of the year, something will start to change. My expectation is by the end of the year, WHO is fully aware that some people are very unhappy with their position, and those people this time will not stop until they win.
And let it happen. Thank you very much.